Good afternoon, and thank you for joining us. My name is Dr. John Ayanian, and I'm the director of the Institute for Healthcare Policy and Innovation and the Alice Hamilton Distinguished University Professor of Medicine and Healthcare Policy here at the University of Michigan. I'm delighted to moderate the panel discussion for today's event. Before we get started, I'd like to go over a few housekeeping notes. Thanks to those who submitted a question on the RSVP form. We will also be using the Q&A function to take questions later in our program. Please add your questions to the Q&A box at the bottom of your screen. I would also note that our discussion is being recorded today. We will begin our webinar with a brief overview of the university's Institute for Healthcare Policy and Innovation, or IHPI, followed by an introduction and remarks from each of our three panelists. This will be followed by a discussion with questions for our panelists. Our event today features three experts connected to their knowledge of healthcare reform and also by their membership in the university's Institute for Healthcare Policy and Innovation, or IHPI for short. For those joining today who are not familiar with our institute, IHPI is the nation's largest university-based organization of researchers focused on health policies to improve healthcare and health. This month, we are celebrating our 10th anniversary of IHPI's founding by the university's Board of Regents in May 2011. Over the past 10 years, IHPI has grown to include 675 faculty members from the university's 3 campuses and 15 of its schools and colleges. Our faculty and students from diverse fields collaborate to help solve major health challenges such as the quality and safety of healthcare, healthy aging, the opioid epidemic, health disparities, and of course, the COVID-19 pandemic. Healthcare is a key area of research and policy work for IHPI. Our faculty evaluate how policies related to healthcare reform may affect the health and financial well-being of individuals, families, communities, and our state and nation. IHPI is helping to fill a growing need for evidence to shape informed decision-making by healthcare organizations and policymakers. Today, you'll hear from Dr. Helen Levy, research professor in the Institute for Social Research, Dr. Minal Patel, associate professor of health behavior and health education in the School of Public Health, and Professor Nick Bagley in the law school. Prior to our conversation, I've invited each of our faculty members to share a bit more about themselves and their work, including why they were drawn to the University of Michigan and IHPI. Let's begin with Dr. Helen Levy. She is a research professor at the Institute for Social Research, associate director of the Health and Retirement Study, a long-running study of the health and well-being of adults age 50 and older, funded by the National Institute on Aging and the Social Security Administration. She served as a senior economist with the Council of Economic Advisors in the Obama administration, and more recently, she worked on IHPI's evaluation of Medicaid expansion in Michigan. Her research focuses on health insurance, including who has it and how does it matter. Welcome, Dr. Levy.
Thanks, John, for that nice introduction. So let me provide a little bit of background on my work. I first became interested in health policy because of the fact that tens of millions of Americans had no health insurance. And I wanted to understand how this glaring inequality could exist and what we could do about it. And that was about 30 years ago. And for the first 15 years, I would say, of my research career, studying the uninsured in academia was a fairly peaceful occupation in the sense that the political situation meant there wasn't a lot of policy action. And I did a lot of research on employer-sponsored health insurance and how it interacted with different types of public coverage to try and understand why some people had coverage and others didn't, and what policies might do something about that. And after that peaceful 15-year period, in 2009, the game changed when President Obama put health reform at the top of his agenda. And there really has not been a dull moment in health policy since then. There was the ACA itself, and then in short order, the legal challenges to it. the administrative and regulatory attempts to undermine the law coming from the Trump administration, and then the pandemic, which has been, among many other things, a stress test for the ACA. And then most recently, as part of the pandemic recovery effort, we've seen the expansion of some elements of the Affordable Care Act. And as John mentioned, I went to work at the White House Council of Economic Advisors shortly after the Affordable Care Act was passed, which was a great opportunity to observe close up what happens right at the intersection of research and policy. So it's been an eventful decade, and one of the great joys of being at the University of Michigan for all of the policy turmoil of the past 10 years has been the opportunities for collaborative research on these topics. So for example, being part of the team that John mentioned, which he leads, and Minal is also a part of that team, being part of that team to evaluate Michigan's expansion of its Medicaid program under the Affordable Care Act. That's been fascinating. And Nick Bagley and I have written a couple of papers together about the Affordable Care Act. And I believe the first one of those actually grew out of a conversation that we had when we ran into each other while walking to campus. It is a great privilege to be a part of this institution, and I'm excited to be part of today's discussion with all of you. And now I will turn it back over to John.
Thank you, Dr. Levy. Next, we'll hear from Dr. Patel, who is an associate professor and associate chair in the Department of Health Behavior and Health Education at the School of Public Health. Her research focuses on patients' financial burdens and unmet social determinants of health in the context of managing chronic disease. She's developing and evaluating behavioral interventions to mitigate these concerns. And as Dr. Levy said, she's also a key collaborator on our evaluation of the Healthy Michigan Plan, the Medicaid expansion here in Michigan. Welcome, Dr. Patel.
Thank you, John, for the introduction. Hello, everyone. It's a pleasure to be here. Like John said, I'm an associate professor at the School of Public Health in the Department of Health Behavior and Health Education, which is the same discipline that I trained in. I have been on the faculty for 8 years and a member of IHPI since I started my faculty position. I consider myself a social and behavioral scientist, and my training draws on multiple disciplines, including behavioral psychology, sociology, and community and structural health disparities. Central to my work are the social and behavioral determinants of health. And I come to my work in healthcare and healthcare delivery with a lens that behavior change is inherent in many goals to improve population health and make healthcare work for everyone. I'm also trained in the design and evaluation of behavioral interventions at the individual, interpersonal, and community level. So behavioral solutions are at the center of my work. I came into this discipline with the mission to devote my career to tackling access to care and care management issues that patients face, particularly people with chronic diseases. And the types of questions that guide my work that I aim to scale to reach a wide range of people are things like, how can we better support people to navigate the complexities of understanding and maintaining their health insurance coverage? As healthcare has gotten more expensive for people, how do we bridge financial literacy and the management of one's healthcare and their decision-making, especially when policy solutions are still pending? And how do we build the capacity of healthcare delivery and patients to navigate very complex systems such as accessing and assistance programs, financial assistance, et cetera? And when people are managing chronic disease, they have a regular relationship with healthcare. So how can we leverage this relationship to also address other factors that we know are intimately intertwined with one's health, such as food access and stable housing? And most importantly, how do we close the disparities gap and uplift the health of all people in the work that we do? So some of my recent work includes working with federally qualified health centers and social service agencies in Southeast Michigan to strengthen health insurance navigation skills through the promotion of enrollment assisters via storytelling and role modeling techniques. I am also currently leading a large study where we are working with people who have uncontrolled diabetes and experience financial burdens in managing their conditions. We are screening them for unmet social needs outside of the healthcare setting and developing their skills to navigate community resources to manage their needs. And we want to see if these approaches can actually change diabetes outcomes. And we are also looking to explore why some people don't take or use supportive services when they're offered to them. In addition to my research, I serve in several leadership roles, including within my department at the School of Public Health, the Michigan Center for Diabetes and Translational Research, and the National Clinician Scholars Program at IHPI. And the content I apply in my research is also related to what I teach at the university. So I also teach courses on social and behavioral change theory in public health, design science and health communication, and racial and ethnic disparities in healthcare. University of Michigan continues to be a real ideal environment for me to pursue this work. I believe that collaborating across disciplines to address complex issues facing healthcare is truly a must. And Michigan makes that happen, and especially IHPI. IHPI has provided me with research opportunities, including working with members of this panel on the Michigan Medicaid evaluation, as well as mentorship and learning opportunities, and opportunities to connect with researchers with common interests who bring different perspectives. So I really appreciate the opportunity to engage with you and my fellow panelists and look forward to our discussion together today. Thank you.
Thank you, Dr. Patel. Next, we'll hear from Professor Bagley. Nick Bagley is a professor at the University of Michigan Law School. His focus is on healthcare, and in particular, the implementation of the Affordable Care Act. He has written extensively on the litigation related to the Affordable Care Act, including the current federal lawsuit challenging its constitutionality. Welcome, Professor Bagley.
Thank you, John. It's great to be here. So I joined the University of Michigan back in 2010 after spending 3 years at the Department of Justice. My core area of interest and study is administrative law, which is to say, how do agencies implement the statutes that Congress adopt? As it happens, I joined the faculty here at exactly the same time the Affordable Care Act was adopted, which meant that it was right on the cusp of being implemented across the entire country, and of course, also being subjected to a number of very high-profile lawsuits. Once I joined the faculty, I found that lots and lots of questions started being asked about the implementation of this new healthcare law. And I discovered that I could actually start to answer some of them. And over time, I even developed a bit of an expertise in healthcare law. And looking back 11 years later, it's kind of surprising how far I've come. My connection with IHPI actually started in a very personal way, with John sitting down with me in a coffee shop, encouraging me to submit some of my legal writing to academic medical journals like the New England Journal of Medicine, which I'd never considered before. I didn't know that anybody would actually be all that interested in what I had to say. But I thought, okay, well, I'll give it a shot. I dusted off a piece about at the time, the employer mandate, sent it in, and they were good enough to publish it. And since then, I've published in medical journals, in health policy journals, in clinical services research journals, kind of all over, largely because of that entree that I had, that invitation to sort of cross interdisciplinary boundaries way back in the day. As John said, much of my research is focused on ACA reform. I've also written extensively about Medicare reform, about how it may make sense to think about the regulation of medicine more as in a kind of public utility frame of mind. And of course, I've written about the extensive litigation that seems to always be threatening the future of the Affordable Care Act. Last year, I had a bit of a pivot. In March, I joined the Whitmer administration as special counsel on COVID-related matters, and in that capacity, helped draft many of the executive orders that have helped get us through this last crisis. And this past semester, once again, showing how you can straddle lots of different departments here at the university. I taught a class on the regulation of contagious disease in history here in the United States, which allowed me both to touch on, yellow fever in the 19th century, but also to touch on COVID today. Michigan could not possibly be a better place to do this kind of work, and IHPI has been an indispensable resource in bringing people together from across the university on matters that they have a common interest in.
Thank you, Professor Bagley, and thank you to all of our panelists. Now we'll move into the discussion portion of our agenda today with the panelists. We've collected questions in advance, and if you have a question you'd like to ask of our panelists, please submit it through the Q&A function at the bottom of your screen. I'd like to start with some discussion of the Affordable Care Act and where it stands now in 2021, including the recent and ongoing litigation and legislation related to the Affordable Care Act. Professor Bagley, what's your view of where we stand? There's a case pending right now before the Supreme Court, the latest one challenging the constitutionality of the law. What are the prospects for that case, and what might we expect going forward?
Yeah, in its latest brush with death, the Affordable Care Act has been sued by a consortium of conservative states that argue that the individual mandate in the law is unconstitutional. Now, stop me if you've heard this one before. But this latest challenge is a little different. What the challengers here say, and you have to bear with me, this argument is complicated. They say, look, back in 2017, Congress eliminated the penalty for going without insurance. They said they were eliminating the individual mandate. But if you actually look at the text of the legislation that stays on the books, the instruction that people shall buy insurance is still there. Now, it's toothless. It's backed up by a $0 penalty, but the instruction is still there. And the red states say that that naked instruction is coercive. It actually coerces them into buying insurance. That's so even though there's no penalty attached. In fact, they say it's more coercive than it was before, because before the Supreme Court had interpreted the individual mandate to impose only a tax penalty. But now you can't interpret it as a tax. It's just a straight out command, and an unconstitutional one at that. It's an audacious argument, but even more audacious is what they say next, which is that this flaw with the individual mandate should not only yield the invalidation of that shall language, but the entire law altogether, which would pitch, of course, tens of millions of people off of their insurance basically tomorrow. The case, however absurd it may sound, got a pretty warm reception in some highly conservative courts in Texas. The Supreme Court agreed to take the case, and it's now under consideration. Judging from oral argument, the justices are pretty darn skeptical, including many of the most conservative justices on the Supreme Court. We are now waiting for a decision. Nobody knows exactly when it'll come down, but it really could be any day now. I think the good money is that the Supreme Court is going to turn aside this latest effort to achieve through the courts what Republicans can't seem to achieve through the political sphere. But it's anyone's guess, and you never know.
Thanks, Nick. And I want to invite Helen or Minal to comment. And where do we stand from a policy perspective with this uncertainty, and how do states and communities move forward with yet another challenge, fundamental challenge to the laws in place right now?
Well, I'm not sure if Minal wants to take that one or not, but I'm happy to say a big question, and Nick may want to address this, is whether if the court ruled that the individual mandate had to go, it took the whole rest of the thing down with it. So there's sort of that added layer of uncertainty. But I think if you took the whole thing down with it, everything we have known for the past 10 years, from the Affordable Care Act, the Medicaid expansions, the health insurance marketplaces, the tax credits, that would be a catastrophe. And I think one thing we've demonstrated in the past 16 months as a nation is that we're bad at planning for catastrophes. So as far as I can tell, and in this case, that may be sensible because all of the informed opinion, as Nick said, expects the court not to invalidate the Affordable Care Act. So that's my take on it.
Yeah, I would agree with that. And I think people on the ground in communities have seen threats to the ACA for over a decade, closing in on a decade now. So, the health insurance is still there and people are managing it, unfortunately with higher costs. So I think for them, it's really just anticipating what is the next thing with this debate. And quite honestly, with recent polls, it's unclear if everyone really knows about the nuances that Nick pointed out in terms of what is actually going on and what is actually up for debate here.
Thank you to each of our panelists. And what also has changed, with the response to the pandemic? What have we learned about the value of health insurance coverage and, how people have managed through some of the job losses and recovery that we've seen over the past year? Helen, can you speak to some of those economic consequences and the way that it affects people's decisions?
Yeah, sure. I mean, I can say a little bit about the safety net that the Affordable Care Act put in place for people when they lose their jobs, which is in particular what it did for health insurance, which is of course slightly different from thinking about, there's many ways that the pandemic has made us think about health insurance and what it does and doesn't do. But just to think for a minute about what the Affordable Care Act put in place, I think the pandemic has shown us something that we actually already knew, just plain from looking at people who lose their jobs in normal time, in pre-pandemic times. We had already learned that Medicaid expansion combined with the tax credits and marketplace plans had cut the fraction of unemployed people who do not have insurance in half, from 40% to 20%. Now that's still a high number, but it's a lot better than 40%. So if you look at what was happening when people lost their jobs before the pandemic, the Affordable Care Act, and I should say, we know it's the Affordable Care Act because it's an increase over what we saw before the Affordable Care Act, as sort of an improvement in people's coverage, but also it's much bigger in states that expanded Medicaid than in states that didn't. So the Affordable Care Act was already doing a lot of work, and it was doing that. And before we had this sort of mass layoff in March and April of last year. So when those numbers come in, I do expect that we will see that the Affordable Care Act, particularly in states that expanded Medicaid, functioned pretty effectively as a safety net to give people insurance.
Thanks. And Minal, you study chronic disease. What have we learned about how coverage affects people's access to care and how they're treated for chronic diseases like diabetes or high blood pressure or depression?
Well, health insurance coverage is just so critical to that. If you're managing a chronic disease, it's a lifetime of management, and one does need to intersect with the healthcare system on a regular basis. So health insurance affords them the ticket to do that without bearing significant financial burdens of getting their medicines, engaging in healthcare visits without it. And recent legislation from the Biden-Harris administration has absolutely supported that in terms of keeping a vision on making access easier, especially with these special enrollment periods where we saw huge increases in people signing up, especially within the first 2 weeks. And saving money with the recent the tax credits and subsidies that come along with that. So the fact that so many people signed up immediately in the face of huge job loss, I think speaks to the fact that people need insurance, and the fact that 1 in 2 people manage a chronic disease in the US, having that infrastructure is really important.
And can you say a bit more about those special enrollment periods? I think you're referring specifically to the ACA marketplaces or healthcare.gov. Is that correct?
That's correct. Between February and May, they had a special enrollment period where they saw nearly 200,000 people sign up within the first 2 weeks.
And then I know, for example, Helen, in Medicaid, there have also been some changes in terms of the public health emergency. Is that correct? And and allowing people to stay on when they otherwise might have lost their Medicaid coverage in pre-pandemic times.
Yeah, that's right. So there was some changes to the rules that would enable people to keep their Medicaid. And then I think more significantly, the American Rescue Plan, which was passed in March, includes a financial incentive for the 12 states that haven't expanded their Medicaid programs yet to do so. So there's federal money to get access to even more of those people. And they're probably about, in those 12 states that haven't expanded Medicaid, there's probably about 4 million people who would benefit if they did expand.
Yeah. So I want to come back to the topic before we leave this question of the Supreme Court case. Nick, is this the last big challenge we're going to see to the Affordable Care Act? Are there others out there that could make their way to the Supreme Court? I think this is now the third or fourth major challenge that the court is ruling on.
Yeah, it feels like Groundhog Day. Like this one will go away, and then we're going to have another case challenging the ACA root and branch. To be fair, I think each of the cases, the big ACA cases, have kind of gotten weaker over time. This feels like the last full frontal challenge to the law that we're likely to see. But there's going to be litigation over parts of the Affordable Care Act for a long time to come. In Texas right now, for example, there was a lawsuit that's been brought challenging parts of the ACA that guarantee $0 coverage for certain kinds of preventive services and certain kinds of vaccinations. It's the part of the ACA that allows COVID vaccinations to be offered for free through insurers. So those parts of the ACA have been challenged as unconstitutional, and Texas District Court has already said that he agrees with the challengers and that portion of the Affordable Care Act is likely to go down. I think some of the arguments that the plaintiffs are making have some real force. So that part of the law is certainly under threat. And there are all sorts of bits and pieces of the law that have consistently been challenged in this or that context. And surely there will be challenges brought as well to some of the Biden administration's choices about how to implement the law, especially when it comes to coverage of contraception or other hot button political issues.
And Nick, we have a follow-up question from one of our viewers today asking what actually might happen to the law depending on the Supreme Court decision. So in the most extreme case, if the whole law were struck down, would that take effect immediately, or would there be a transition period or an opportunity for Congress to make some changes in response? And similarly, if the parts of the law were struck down, like maybe the individual mandate and the marketplace coverage that relates to it, or the subsidies that relate to it, how might that play out?
God only knows. It is extremely complicated, and the short answer is we've never seen the Supreme Court, invalidate a major piece of legislation more than a decade after it was adopted and more than half a dozen years after it was fully implemented. So we're in uncharted territory. In all likelihood, the decision would take effect immediately. The Supreme Court, once in its distant past, would say things like, well, we'll just invalidate it starting 6 months from now. But the court in more recent years has said that looks a lot like legislating, like you're setting an effective date for a statute instead of just calling balls and strikes. So the court is unlikely to enter a stay of its decision, although it could, I suppose, which means it would take effect kind of immediately. And that would have very complicated consequences. For people on the exchanges, they've entered into year-long contracts, but many of them would be unable to pay the premiums on those contracts. So as soon as they fail to pay their premiums for a 30 to 60 day period, they're going to get kicked off. Medicaid money would stop flowing out of the federal treasury overnight, in which case most states would have no choice but to drop their expansion populations because states can't handle the budgetary implications of covering everybody on their own dime. But those kind of can't, it's almost the mind reels trying to figure out how it would work because, even hospital systems are paid through mechanisms created by the Affordable Care Act. If those were ripped out, how would you just, go through the basic plumbing of getting, hospitals paid for nothing, for a procedure that has nothing to do directly with the ACA? The complexities here are mind-numbing. The way I think about it is like the Affordable Care Act, built onto an existing home, it kind of changed part of the plumbing. And now what the challengers want to do is just rip the plumbing out. And you can't do that and just have the home as it existed before. You're going to have water gushing everywhere. And that's likely what we're going to see. Could the court pull out fewer bits of the ACA? They could. It's interesting, the challengers here and the government, but rather the state of California, which has stepped in to defend the law, they have not taken that more moderate position of just strike down little bits and pieces of it. It's either strike down the whole damn thing or really nothing. Maybe you strike down the shall language, but who cares at this point? It's backed up by nothing. But like that kind of all or nothing aspect to this is kind of, it's kind of an extraordinary feature of the litigation. And it's one of the reasons I think the Supreme Court is unlikely to bite. There's no moderate way to issue a decision here.
Thanks, Helen.
Yeah, I have a follow-up question for Nick. So my understanding is that given that the sort of legal argument for ripping out the plumbing is based around the fact that there's no money attached to the mandate and therefore it can't be considered a tax, that one way you could keep the plumbing from being ripped out is if Congress were to act to add a tax, change the tax from $0 to $10, and then the legal framework returns and the whole thing doesn't get ripped out. That would be interesting politically, but first of all, do I have the legal functioning there correct?
Yeah, absolutely. They could probably do it with, adding a penny tax to it, and that would be enough. And in fact, I encouraged, in my public writing, Congress to do exactly that several years ago, saying this lawsuit is more serious than you think. It is coming down the pike. You could put a stop to it right away. And Democratic leadership thought, well, if we can't get it through the Senate or past Donald Trump, Democratic leadership in the House had no particular interest. And they had no interest also because they felt like it would be signaling that they took the lawsuit more seriously than they thought it was worth. And after Biden was elected, there was some speculation that maybe now through reconciliation, Congress would just add a penny tax or a dollar tax. But again, Democratic leadership decided that they would run the risk and not attempt to put their members in a tough spot of having to vote for the individual mandate.
But don't you think, Nick, that if the Supreme Court actually said throw the whole thing out, the Republicans at that point are the dog that caught the mail truck, right? Except it's worse than the mail truck. They caught something much worse than a mail truck, right? They caught something that takes away programs that millions of people, including Republicans, totally rely on. And as you observe, it's not just Medicaid. It's all this stuff. And so, the Republicans are going to be in a tough spot then too.
And it impacts Republicans if millions of low-income adults become uninsured. That has huge impacts on the economy that affects everyone.
Yeah, I mean, if Medicaid is destroyed, it's billions of dollars flowing to the states every single year. No, Republicans, if you actually look at their public messaging, they want nothing to do with this lawsuit, right? They express sort of rhetorical support for ripping out the Affordable Care Act, but when you look at actual contested Senate races, they run as far from this litigation as humanly possible. Mitch McConnell filed an amicus brief in the early Affordable Care Act cases saying you should strike down this law. He has been noticeably absent this time around. I think Republicans know this is not a case they actually want to win. It's a case they want to fundraise on, which is something quite different. But the Supreme Court is a bunch of independent-minded people. And although they certainly get the signals that this is probably not a good thing for Republicans if this case were to prevail, they may have their own independent views about what the law requires. So, we'll all be watching closely. I think the case still remains a long shot, but, the small chance of a very bad thing happening is certainly worth worrying about.
I didn't mean to suggest that I thought that justices would be influenced by that, but rather that in the event of an adverse outcome, there might be a rather hasty congressional vote.
I will go further. I do believe the justices will be influenced by the fact that the Republican Party is signaling as loudly as it can, please, please, please don't give us what we're asking for.
So when we talk about healthcare reform, what are the role of voters? And Nick, you touched on the in the last election, this was not as prominent an issue as might have been expected. And another litmus test we have of voters is what's happened with Medicaid expansion in several states, several red states in recent years, such as Idaho, Nebraska, Missouri, where voters have been given a choice whether to expand Medicaid when their state legislatures or governors had chosen not to. And in each case, the voters, a majority, have voted in favor of Medicaid expansion. But what does that tell us about the role of public opinion in healthcare reform? I'd offer that to all three of our panelists.
Yeah, Medicaid is popular. I mean, you give it to a vote and people want it. People want health insurance. The trouble is that, committed Republicans, the kind of hard right of the party, has a different view. And many red state politicians are in districts where to win election, they've got to satisfy a very rabidly conservative Republican primary electorate, and they don't face much of a general election challenge. And so you have this weird situation where the Republican Party as an institution ends up supporting policies that are actually pretty unpopular on the ground. I don't know how long-term sustainable that's going to be, but I will say that for now, we've got, as Helen said, about a dozen states that don't wish to expand, and we've got state legislatures that are actually, in several states, pushing back hard on a referendum where voters have said we want Medicaid, and the legislators are saying over our dead bodies. It doesn't look like the extra money that the Biden administration put up for Medicaid is likely to move Texas and Florida and other red states into the yes column. This has become such a partisan issue that I think it's very difficult to, just get down to basic things that are popular, which is, do you want money for your state? Yes. Do you want health insurance for your citizens? Yes. For some reason, that just does not seem to move the holdouts.
I think it's even a little weirder than that, because in a couple of cases, you have statewide, you have Republican governors who are refusing to implement ballot initiatives that have been passed. So that happened in Maine, which I think they had to wait 2 years before their governor changed, and they got a governor who would actually implement the law that had been passed by the voters of Maine. And then currently in Missouri, there's a Republican governor who's refusing to implement the Medicaid expansion that was passed on a ballot initiative. And in both of those cases, they offer, so those are sort of statewide Republicans. It's not just the sort of, I'm staking out, my far red territory because I'm part of the state. Those are statewide folks. And in both of those cases, they made the argument, oh, we can't afford this because the state has to pick up formerly 10% of the cost of the expansion, which of course is, anybody knows that 90% off something is a good bargain. And then as John observed, recently the government threw in, actually, we're going to mark it down another 5%. So now it's 95% off and nobody's biting. So yeah, it's not clear what to do in that situation.
So I want to shift gears. We've talked about some of the debates on the conservative end of the spectrum. If we move to the more liberal or progressive end, we've got some fairly heated debates about Medicare for all, and we had a number of questions posed in advance about kind of what might happen with Medicare for all. And I wonder, what do you each think about sort of how that might play out? Is there a public opinion in support of it? Are there votes in Congress to support Medicare for all? And what might the rationale be for that as a different approach from the Affordable Care Act? And Minal, I might turn to you first to see your thoughts on that question.
Well, I think we need to do a little more to educate voters, especially when it comes to health policy. And we need to make it easier to understand, because there are some polls out there that show half of respondents don't even know what Medicare for all is. So where do we go from there if half of respondents don't even know what it is and they're voting?
And do any of you see a case to be made? Could there be political momentum, or are we likely to be living with the Affordable Care Act over the next decade?
Yeah, John, I'm always befuddled by this conversation. Whatever you think of Medicare for All on the merits, there's a blunt fact, which is that there aren't 60 Democratic votes in the Senate, period, full stop. And Republicans are definitely not on board with the notion for Medicare for All. So unless you've got a magic recipe for getting rid of the filibuster, or you have a wave election of a kind we're unlikely to see in 2022, I just don't know how you get from there to here, or from here to there. Like it strikes me as an aspiration more than at this point a realistic political program. Now, as aspiration, maybe it's good to kind of place an ambitious target, but it's an ambitious target that I don't see any hope of realization in the near to medium term. I also say that I think a lot of people, when they say Medicare for All, what they really mean is, let's make sure coverage is truly universal and let's make sure it's cheaper for us. I don't think people actually care all that much about exactly the mechanism through which they receive their coverage. I think most of them, as Minal suggested, don't really know like exactly the details of how they're covered, and they don't much care. So I view these problems from the perspective of, like, if you want to solve the problem, there are lots of ways to solve the problem. Every developed country in the world has solved the problem, and they do it in lots of different ways. Medicare for All is one of them, but it's only one of them of many. What I don't see is any real desire to move us decisively in that direction. I mean, I don't see enough political support to move us a half a step in that direction. So I don't know why Medicare for All is taking up as much airtime in the discussion as it is.
Helen, what about the option that President Biden ran on about potentially lowering the age of eligibility for Medicare? That obviously is not as dramatic a change as Medicare for All, but does that policy option have merits? And if it does, might we see that in the next few years?
Well, I don't know if we'll see it. I mean, the Biden, candidate Biden and now President Biden have has put forward a bunch of sort of what I would call incremental expansions, fixing the gaps in the safety net that was created by the Affordable Care Act. So making the premium tax credits more generous, lifting the income cap at which you no longer qualify for premium tax credits. And I think of lowering the Medicare eligibility age as sort of like that. You can do it. It's going to move some people around from one coverage bucket to another. But fundamentally, for me, when I think about what does Medicare for All mean, because I do think there's a ton of confusion about what we mean when we talk about it. Like, do we really mean Medicare as it exists for all with Medicare Advantage or not? Like, there's all these details. So for me, it comes down to, are you going to throw the purchasing power of the government as a monopsonistic purchaser of healthcare, that is to say, the only game in town? Are you going to throw that purchasing power at the healthcare system and say, okay, we're telling you what we're paying. You don't set prices anymore. And in order to do that, you got to have everyone in. And that's not the system that we currently have. So, right now, there's all these different payers, and they all either negotiate or set prices, in the case of Medicare, a little bit differently with the providers. And so all of which is to say, an incremental move like changing the eligibility age, you could do that, but it's not going all in yet. It's not saying, okay, the only way to get these costs under control is to use our monopsonistic purchasing power, and we are going to do that. So to me, that's that. I haven't seen anyone behind that yet.
You raised a good point about the costs of care. We had a number of questions in advance of today's event about costs of healthcare. Minal, what happens to people who can't afford healthcare in a crisis? And one example might be when you need care for cancer, a new diagnosis of cancer. And this is a topic that you devoted some of your own research and policy focus to.
Yeah, I'd love to answer that question. So basically, loosely offering some sort of assistance, like posting a flyer in a clinical room, for people to maybe see is just very inadequate. When people try to shoulder the costs, the numbers here, especially in cancer, are really grim. So between 40 and 80% of cancer survivors exhaust their savings to finance medical expenses. Up to 34% of patients with cancer are borrowing money from friends or family to pay for care. And bankruptcy rates among people with cancer are 260% higher than among similar households without cancer. So when we're not preventing or even addressing any element of what folks have coined financial toxicity in cancer care, this leads to early termination of effective therapy. It leads to reduced quality of life, high symptom burden, and documented early mortality. So even patients with cancer who declare bankruptcy, they have a 79% greater mortality risk than those who had not. So they're nearly at 80% risk of dying because of the cost of cancer care. And healthcare organizations absorb these costs, so it impacts their financial viability. So the costs in cancer care are really eye-opening in terms of needing to do something about it. And most cancer care delivery settings are offering some sort of financial counseling, but they typically provide like a limited scope of services to a limited population, and they lack any sort of systematic identification of financial needs. So we really need to implement comprehensive financial navigation services as part of cancer care delivery if we're not addressing the costs of cancer care directly immediately. We need to be able to support our patients around this.
Helen, as a health economist, do you have any thoughts about some of those statistics that Minal was quoting from her research and others? How do we implement a healthcare reform set of policies that can tackle some of those considerations when people's health and survival is in crisis?
Yeah. Well, I mean, one of the things we've learned from things like Medicaid expansion is that health insurance does matter for mortality and access to care, but it really matters a lot for people's financial well-being. So as you know, John, the Michigan Medicaid expansion, people's credit scores got better sort of right away, even if their access to care sort of changed slowly over time. When I think about this, and I've been involved in research where we sort of think about trying to counsel patients into having conversations with their doctors about how much a drug costs or something. And sometimes at the end of the day, after thinking about that research and trying to improve people's financial literacy, I just think, we should really just have a much higher income threshold for Medicaid, like 200 or 300% of the poverty level, right? And then let everybody above that. So it's a little bit different from Medicare for all. It's more like Medicaid for many, many more people. And that would, because then Medicaid has very little cost sharing. And then you have people with very little in the way of resources not having to confront a lot of cost sharing. So yeah, that would be one approach.
Thanks. And Minal, coming back to you, obviously, the pandemic has been, tragic for many individuals and communities over the past year. What have we learned about social determinants of health and structural racism and sort of the disproportionate impact of, and what that tells us about the healthcare system, the insurance system, and the healthcare delivery system that we have in place, as well as our public health infrastructure, which has been such an important part of responding to the pandemic?
Absolutely. So the healthcare system, by one estimate, is responsible for only about 10 to 15% of preventable mortality in the US, and socioeconomic factors such as housing, food, education, all have a greater overall impact. So there is definitely growing recognition and investment in addressing these health-related social needs, especially through enhanced clinical and community linkages that can improve health outcomes and reduce costs. So there's even a CMS innovation model that came out of the Affordable Care Act, accountable health communities, to really understand how this can work with Medicaid and Medicare beneficiaries. And this work has become even more important because of the pandemic. I mean, we've seen 4 out of 10 low-income Americans struggling to afford putting enough food on the table. Nearly every state having significant increases in unemployment, concerns about the ability to pay rent and mortgage, really at unprecedented levels. At one point, 1 in 3 American renters did not pay rent. So given that this is really a wide segment of the population, social determinants will have to be front and center in any sort of health policy moving forward. And addressing another part of your question in terms of structural racism. So race is a social determinant of health, and more recently a spotlight is shining on the fact that structural racism has never been a thing of the past, and unfortunately it continues to thrive in everyday life and truly harm people. And for many decades, American medicine has discriminated against people of color. Many choices that providers commonly make, such as not accepting Medicaid patients, having fewer staff members at facilities in primarily minority inhabited neighborhoods, and blaming patients for not taking their medicine or poor overall health outcomes. All of these things perpetuate and widen disparities. So there's really a lot to do in healthcare and health policy to end structural racism.
Thank you. Well, in the few minutes that we have left, and to close our discussion, I'd like to spend a moment talking about the importance of philanthropy in the work that we do at IHPI and across the University of Michigan. Many of you watching today generously support the university, including IHPI. And I'd like to ask our panel to share their views of how philanthropy impacts our ability to better understand healthcare policy and the healthcare reforms that are needed, many of which we've been discussing today. And I might start with one example. At IHPI, we're very grateful to the support of a donor who has allowed us to create a program called Policy Sprints. Those of you outside the university may not know, but oftentimes when we develop a new research project, it can take 2, 3, 4, even 5 years from the start of a project till the time when we have meaningful results to share. And with support from a generous donor, we've been able to create a program that's much more rapid. We title it Policy Sprints, where we encourage our faculty and students to develop important projects that be completed quickly within the period of 3 to 6 months at most. And one example was last year, we had one of our national clinician scholars, a surgeon in training, learning the research methods at IHPI, conducting a study of surprise billing. That's when people are faced with healthcare bills because they get care from a physician or hospital outside their network. And that's been a really contentious issue. And through some very cutting edge research guided by some of our IHPI faculty, a team was able to do important work on surprise billing, and it helped to inform legislation that Congress passed at the end of 2020 to address surprise bills and reduce their impact in some of the ways that we've been discussing today of people getting hit with particularly high healthcare bills. So that's just one example. And I might turn to our panelists to get your perspectives on how philanthropy can help us do our work more effectively and have an impact beyond the university on some of these important healthcare issues we're discussing.
I can follow up, John, by saying that a lot of the work on that IHPI does on the evaluation side is not only useful for shaping legislation, but has a direct impact on regulatory choices that the executive branch makes and on litigation. So we've seen this most acutely with the Medicaid expansion, which we've seen lots of wonderful research come out of IHPI about the value and benefit to people, about the fact that it doesn't burden state budgets. All of that research helped to inform the Biden administration's recent efforts to put a stop to work requirements in Medicaid. Those research studies are right on the face of their decisions. So it has a direct tie-in to actual policy happening on the ground.
Thanks,
And I
Helen.
think also, if you take sort of a slightly longer view, going back historically, and you think about the body of evidence that was in place to support the enactment of the Affordable Care Act. You know, all of the research on the uninsured, that was all funded by philanthropies. This was not a hot topic for a long time, but there was a substantial evidence base about what the benefits of what the policies could be and what the different costs and benefits of the different policies would be. That meant that the legislation that was passed was very informed by that research, and that research did all rely on, almost all of it was funded by the Robert Wood Johnson Fund, the Kaiser Family Foundation, the Commonwealth Fund. So the role of philanthropy in getting the research infrastructure out there for informed policy change, I think you can't possibly overstate how important that was.
Yeah, piggybacking off of Helen, it can also fund really important initiatives that may not be politically popular, but really necessary to improve population health. For example, under the prior administration, there were real threats to research on racism. And, you know, we can't always depend on the administration to really set the research agenda. So your philanthropy really helps in terms of moving forward really important and pressing questions that may not fit the mold or timeline of traditional funders.
So thank you to our panelists and all of you watching for participating in today's event. As a reminder, this session has been recorded and a video link will be sent as a follow-up that can be shared with others who were unable to attend. Please look for additional information about IHPI and healthcare reform by visiting the IHPI website at ihpi.umich.edu. Follow us on Twitter at @UM_IHPI and sign up for our monthly newsletter, IHPI Informs, to learn more about our work to improve the quality, safety, equity, and affordability of healthcare. If you're interested in learning more about supporting IHPI research and policy work, please fill out the survey you'll receive following today's event. And thank you everyone for your generous support of IHPI, Michigan Medicine, and the University of Michigan. Go Blue.